Hello, everyone, and welcome to the Brian Grant Foundation monthly wellness webcast. I'm Amy LaValle, your community liaison, and I'd like to thank you for joining us. We have a terrific topic for today, one in which I'm very curious about but know very little, the gut microbiome and its role in Parkinson's disease. If you have any questions during the webcast, please put them in the chat box below, and we'll do our best to get to them. Microbiome has been implicated in the development of many chronic illnesses, and research strongly suggests a link between the gut and Parkinson's disease. We welcome Dr. Delaram Safarpour, an associate professor of neurology at OHSU and the medical director of the Deep Brain Stimulation Program, whose research has included gastrointestinal dysfunction in Parkinson's disease. She will discuss the role of the gut microbiome for people living with Parkinson's and dietary management. We thank you for joining us today, Dr. Safarpour. I'm going to hand this over to you.
Thank you. Thank you, Amy. Thank you for your kind introduction. I am going to talk to everyone about gut microbiome, as you mentioned. Let me, with that, go ahead and share my screen. I'm hoping you'll see my slides now. Yes? You see my slides. Okay, perfect. All right, so again, hi everyone, good afternoon, and thank you for the invitation. I'm one of the movement disorder doctors at OHSU, and as Amy mentioned, my special interest is in GI dysfunction in Parkinson's disease, along with deep brain stimulation and its effect on outcomes of life for patients with Parkinson's disease. Today, we're really going to focus on the role of microbiome in pathology of Parkinson's disease and the theories that there are for development and spread of this pathology to the brain and how it can affect symptoms of Parkinson's disease. At the end, we will have some time for questions as well. So let's start with the fact that Parkinson's disease, which was at one point thought to be really a motor disorder, is really not just motor, but also includes a lot of non-motor symptoms. And when James Parkinson initially in 1817 described the disease, he had in his essay of Parkinson's disease mentioned about the role of GI dysfunction in presentation of the disease as well. And these are quotes from that essay on shaking palsy, that he mentions that so much are the actions of the muscles of the tongue, pharynx, and he also mentions difficulty with swallowing. He also mentions saliva failure. These are all the symptoms that we often see actually years before onset of motor symptoms. So a lot of times when I ask my patients about presence of constipation, they mention that they've had it for a long time. And this is what we know that actually is true, that in Parkinson's disease, constipation can happen decades before onset of motor symptoms. And the different parts of the GI tract are all involved. As you can see, involvement of all different parts of GI tract in starting from the oral cavity, the movements of the tongue, the jaw movements that are slow, along with swallowing dysfunction that is there, will cause difficulty with drooling. So patients often will say that they have some drooling, they may have some difficulty with swallowing, they have constipation, early fullness. So symptoms from all different parts of the GI tract that have been known ever since we've known Parkinson's disease, really. Now, the truth, though, here is that if you look at PubMed, where all the literature from years ago are gathered and accumulated, when you search Parkinson and gut and look at the number of publications since years ago, you see that there wasn't much publication on the gut in many years ago. And it was not until the most recent decade that there was much more interest in effect of GI dysfunction and how the GI system is involved in Parkinson's disease and how it can interfere with response to treatment. And so we're learning more and more as we go about the effect of the GI tract. Obviously, one of the important things that we know is that when you compare patients with Parkinson's disease with controls, you see that patients with Parkinson's disease have a lot more difficulties with drooling, swallowing difficulties, with nausea, and the blue bars are control patients of same age. When you compare patients with Parkinson's disease with controls that don't have Parkinson's disease, you have all these other symptoms that are more common in PD patients, and PD stands for Parkinson's disease. So they have decreased frequency of bowel movements, defecator dysfunction. These both can cause constipation. So sometimes constipation can be because of motility issues, because you just have a slower motility of the GI tract. And some other times it can be because of the pelvic floor muscles that are very disorganized and in fact dystonic even, that they go into a sustained movement that they don't allow the act of the bowel movement to happen easily. So both of these can cause constipation in these patients, and they both are affected more than controls. There's several studies that have looked at different parts of the GI tract, like I talked to you before. And here you can see that the submandibular gland, which is one of the glands that produces saliva, is infected, not infected, well, it is affected, I should say. And they have seen the pathology of Parkinson's disease or alpha-synuclein, the phosphorylated alpha-synuclein that is present in the submandibular gland. It is present in esophagus, in a stomach, in appendix and colon. In all different parts of the GI tract, they have seen the pathology. And therefore, we can assume that all these symptoms can be present because of the involvement of all different segments. So, for example, we have motility issues in the stomach. We have motility issues in the stomach that result in early fullness or feeling of nausea, or feeling that your medications, when you take them, don't quite kick in as fast as they should. And sometimes this stomach doesn't really feel like pushing the yellow pills or Sinemet out to the small intestine where it needs to be absorbed. So it's lazy, the motility is slow, and therefore you can see that you took the medication and it's been 30 minutes, it's been an hour, it's been 45 minutes. It is very erratic. And sometimes it kicks in after 30 minutes, some other times after an hour. This can be merely because of motility issues, can, at least to some extent, that the pill has not reached to where it needs to be absorbed. In the same line, small intestine also has motility issues. And when the small intestine is slow, the bacteria growing in the colon will find their way back up to the small intestine and start growing where they shouldn't exist. And when they start growing there, they create a condition, what we call SIBO, you might have heard, or SIBO stands for small intestinal bacterial overgrowth, SIBO. The small intestinal bacterial overgrowth itself can cause some problems, such as your medications may not quite absorb well, nutrients may not absorb well, and the erratic response to medication can happen, and a lot of other GI symptoms like bloating can be quite disturbing as well. These are some of the symptoms of small intestinal bacterial overgrowth. We talked about motility issues in colon as well, and constipation that I mentioned is one of the common symptoms that we see. All parts of GI tract is involved with that. So I have mentioned alpha-synuclein a few times now, and so I wanted to talk to you about alpha-synuclein a little bit because we are going to hear more and more about it. Alpha-synuclein is a neuronal protein that regulates a neurotransmitter release. So it is important for a normal function, and it's abundant in the brain, and also smaller amounts of it can be found in heart, muscle, other tissues. In Parkinson's disease, alpha-synuclein is misfolded, and it's a process that is believed to be because of many different factors, such as what we have. I have written here: oxidative distress, or other reasons that can cause misfolding or phosphorylation of alpha-synuclein. And the hallmark of Parkinson's disease really are Lewy bodies and Lewy neurites that we see here. And these are really what we see in abundance in patients with Parkinson's disease when we look at the brains. So this is just an intro to what alpha-synuclein is and how that is important. And as we move forward, I talk more about it. So here, what I'm showing is the epithelium of the GI tract, and within the GI tract we have what we call microbiota. I'm going to talk about the microbiota a lot more, but for now, these are millions and trillions of bacteria that exist within our GI tract, and they're affected by many things. They're affected by our health, they're affected by our immune system, our diet, sex, our so male and female, different type, or like age, I should say. These are all things that affect microbiota, along with other things like our medications, other medications that we take, antibiotics. These define our microbiota. So microbiota can be affected if there's a process that's going on that changes the microbiota from an anti-inflammatory to a pro-inflammatory. Any stressors that can involve changes in microbiota can cause increase in abundance of certain bacteria and decrease in some other ones. And therefore, when you see that the microbiota has changed and become more pro-inflammatory, along with that, the gut barrier also changes. And these junctions between cells, from tight junctions, they almost become kind of leaky. When they become leaky, you can see that the endotoxins can pass through and activate immune activity within the blood, or where underneath this we have the enteric nervous system, and you can see that the effect of changes in the microbiota can go through the junctions and have an effect on the nerve cells immediately. And when they go through these immediate enteric nervous system, they go through what we call dorsal motor nucleus of vagus, and through that they can go to the brain. And that's how one of the theories that your changes in microbiota can directly have an effect on alpha-synuclein phosphorylation and misfolding, and therefore the message can get to the DMV and then from there to the brain, and can start the process of Parkinson's disease itself. So this is a diagram that shows what I just mentioned, that environmental toxins and changes in microbiome from a anti-inflammatory to pro-inflammatory, what we call dysbiosis. Dysbiosis can stimulate the pathology to start happening, and you can have inflammation and then leaky gut, or those junctions can be leaky, and then alpha-synuclein accumulation in the enteric nerve cells and transport through the vagus nerve into the lower part of the brain, and then gradually to the higher part of the brain, and we will see changes as we go through different parts. this is a Broca staging of Parkinson's disease. The reason why I wanted to show this to you is to have a better kind of understanding of how the system works here. One of the theories in development of Parkinson's disease is that Parkinson's disease can start in the gut, and as I mentioned just in diagram before, from the gut can find its way to the brain. And this theory is called gut first or body first theory. This theory says that it can start in the GI tract, and from the vagus nerve, it can get to the lower parts of the brain. These are the areas of the brain where dream enactments are, and you can see that in these patients years before starting motor symptoms, and by motor symptoms I mean tremor, rigidity, stiffness, all those motor symptoms of Parkinson's disease, maybe years before their Parkinson's disease was severe enough that they could diagnose with motor symptoms. These patients had constipation because this was gut first, and then developed dream enactment, REM behavioral disorder, dream enactment where they act out their dreams, yelling, screaming, shouting as they're asleep, kicking their bed partner. And then as the pathology goes higher up and involves the motor parts of the brain, you start seeing that these patients will develop motor symptoms, and then gradually will go higher. And once it gets quite more to the cortical parts of the surface of the brain, it can include emotional, cognitive disturbances as well. So this is a pattern that we see in this theory that we call gut first or brain first. I'm sorry, gut first or body first theory. The other theory that there is no, some people don't have constipation and they don't have dream enactment, but they do have Parkinsonian features. That theory is called brain first. And there is a lot of back and forth. There are researchers that believe that there aren't two different pathways, and maybe these two pathways coexist, at least to some extent. Some people have some of this and some of that. There are some research that shows that when you look post-mortem and you look at autopsies, there are some patients who only have the pathology in the brain, but don't have it in the GI system. So those researchers will argue and say, if it is started in the gut, so we should always have it in the gut and the brain. Why is it that we're seeing in these patients that they only have the pathology in the brain, but not in the gut? And the counter argument there is, it is possible that you didn't do the autopsy of the entire length of the GI tract, and GI tract is huge. It's like a football kind of field. So if you can't really do autopsy of every single segment, you can't possibly say that it wasn't in the GI tract. So maybe it was, and we missed it in the autopsies. Or maybe there's just a stage that it goes through the gut and to the brain. And then after that, a stage of passing through the vagus nerve. If you do the autopsy of the vagus nerve, you won't see it in the vagus nerve anymore. So there are lots of back and forth between these two theories. But the bottom line is, it is possible that we have two different types, or we probably have more than two subtypes of Parkinson's disease. But we probably have some people who start having symptoms in the gut first. And like I mentioned, these are people who have a lot of constipation, REM behavioral disorder, and then will develop motor symptoms like tremor, rigidity. Or there are some other people who are brain first and have all these symptoms, but don't quite have constipation, and in fact have completely regular bowel movements. So this slide is a better picture or diagram of what I just mentioned, whether the vagus nerve that connects the gut to the brain is really the highway of this alpha-synuclein expression, and how it gets through this highway from the gut to the brain. Is that the case? And is that the case in majority of patients or not? That's one of the things that is still a question. So as you can imagine, there are many studies that are looking at staining the GI tract, staining to find out how many years prior to the motor symptoms you can have this pathology in the GI tract, and how it spreads, how is the mode of a spread of the disease from the GI tract to the brain. And these are what you're seeing here. Barak and his colleagues have published that the gastric involvement is seen very early. The Lewy neurites and Lewy bodies are seen in the gastric tissue. And here is another diagram of what I showed earlier. That's microbiota is here, and then through the leaky gut, you can see the enteric nervous system is just underneath the mucosa. Mucosa is really what is in contact with the microbiome. And in the submucosa, we have all these nerve endings. And if you have enough of the endotoxins or the inflammatory markers bothering the nervous system, the message can itself gradually get to the through the vagal nerve and dorsal motor nucleus of get to the lower part of the brain. So these are all the things that have been carefully studied. Here's another interesting picture of alpha-synuclein in colon in early Parkinson's disease. The pictures on the right are magnification of the pictures on the left. There are a lot of studies that compare patients with Parkinson's disease to people who have inflammatory bowel disorder, like Crohn's or ulcerative colitis. And what they have compared here is that in people who are control is down here to people who have inflammatory bowel disorder, to Parkinson's disease. You see that alpha-synuclein staining is quite positive in Parkinson's disease patients. The magnification shows it even better. In IBD, in people who have ulcerative colitis or Crohn's, these patients have these oval-shaped bodies that are not quite known what they are, but they're staining for alpha-synuclein staining. And in controls, you see nothing as we had imagined it would be. And this, like I said earlier, it's in the submucosa of the colon, and this is the submucosa layer. So they're looking at that layer, looking at the alpha-synuclein staining, and they see that there may be some correlation with the staining in people who have PD and IBD. Then this study looked at the biopsies of colon biopsies of patients 2 to 5 years before their diagnosis of Parkinson's disease. And these studies are very interesting because patients often have colonoscopies or sigmoidoscopies for different reasons. So if we go back and look at these biopsies and stain them and see 2 years ago what was the staining like, this study looked at the staining before onset of the motor symptoms or diagnosis, and you see that in patients with Parkinson's disease. This is a patient with Parkinson's disease that you can see that even before onset of motor symptoms, they had significant staining. And this is healthy control who didn't have any positive staining. These are different people. This is one case, different person, but they all, before their diagnosis, had their different level of presentation of alpha-synuclein staining. Another interesting study looked at not only the staining between healthy controls and Parkinson's disease, but also looked at permeability of the gut in Parkinson's disease versus controls. And permeability is the same as what I was referring to as really leaky gut, where you can have like the junctions are not as tight, and you can have more open junctions that allow for the endotoxins to pass through and affect the nerve endings. And in this study, they showed that the permeability is much more in patients with Parkinson's disease. So giving the GI symptoms are the most common non-motor symptoms in Parkinson's disease, and how the entire length of the tract is involved in Parkinson's disease, and how several of these symptoms may improve with dopaminergic treatments, and the fact that the GI symptoms can precede onset of motor symptoms in Parkinson's disease, at least by a few decades. We can assume that GI system really is closely related to the brain and its well-being. So much so that we think that GI system is a mini brain, really. Now let's move on to microbiota. I mentioned briefly earlier that microbiota are the millions and trillions of bacteria. There are different species of gut bacteria in healthy individuals. There are more than 400 different types that exist in the GI tract. This microbiome is really established at birth and is relatively stable throughout the life of an individual, and can really change if people have major changes in geography, so the different continents and stress, infection, medications. These are different things that can affect it, like I mentioned before. But what we like to have is a happy microbiota, as opposed to a very pro-inflammatory microbiota that can cause some worsening of symptoms, especially in Parkinson's disease. What are the functions of gut microbiota? Different things that microbiota is responsible for. Microbiota is responsible for metabolic balance in our body. It is responsible to prevent growth of pathogens that create different disorders. It's also responsible for synthesis of vitamins, different vitamins like B12, folate. And it can be responsible for our immune status as well, and certainly is responsible for absorption of medications and release of neurotransmitters, different neurotransmitters like dopamine, serotonin, and others. I brought this picture back here just so I can tell you that the gut microbiota is closely in the proximity of the enteric nervous system. And in the previous slide, I mentioned that there are like more than 400 different species in the microbiome. Some of them are the ones that I'm going to talk to you about a little bit more, such as Prevotella and Enterobacteriaceae. These are the species that are especially important because it seems that they're different between patients with Parkinson's disease and controls. And the rest of these points I already mentioned, so I will not bore with you with that. But these are the two species that I'm going to talk to you a little more about. Before we get there, let's talk about the infections and how infections, different infections within the GI system can have an effect in the microbiome. There are different bacterial components. Each bacteria, for example, has components like lipopolysaccharides or amyloid protein. These are different parts of the components of the bacteria, and they are shown to enhance alpha-synuclein aggregation, and this is also supportive of the fact that if you have any component of the bacteria that enhances or increases the aggregation of alpha-synuclein in the gut, that can be responsible for initiation of the pathology of Parkinson's disease or other synucleinopathies. And other infections, even with gram-negative bacteria that we may be exposed to, these bacteria can also trigger aggregation of alpha-synuclein. We talked briefly about the small intestinal bacterial overgrowth, but I want to mention H. pylori here as well. There are some studies that show that infection with H. pylori also can change the microbiome environment and make it more pro-inflammatory, increase the oxidative stress in the system. And there are some studies that show that people who have H. pylori infection, they have actually worsening of their motor symptoms in Parkinson's disease. And some studies that have shown that if you treat H. pylori, they can have better response to their levodopa, they can have better symptoms. But one more recent study that was placebo-controlled and double-blind, which is a high-level study that is trustable, really, showed that treatment of H. pylori infection does not improve motor function in Parkinson's disease. And therefore, if you have someone with Parkinson's disease who has fluctuations and not good response to levodopa, there isn't an indication for going after H. pylori from a Parkinson standpoint. However, H. pylori, we know this infection is responsible for many badness in the stomach, for cancers and other stuff. So we always encourage patients that this is something that you should talk to your primary care if you have symptoms of possible H. pylori infection. That is separate than your Parkinson's disease, and that has to be followed and treated appropriately. But for the purpose of fluctuation, meaning the levodopa is not, it kicks in and then wears off, and you're going through ons and offs in your cycle of levodopa, that itself is not an indication for going after H. pylori. One of the other things that I want to mention here, since we talked about fluctuation, is the effect of bacteria on processing levodopa or breaking levodopa. When we take levodopa changes to dopamine by effect of an enzyme, and this enzyme, ideally, we want it to work just in the brain, but the enzyme also works in the periphery and changes levodopa to dopamine. So not all the levodopa that we take gets to the brain and becomes dopamine. Some of it in the periphery also is going to be decarboxylated. So that's why we take the levodopa with carbidopa to kind of break that or kind of stop that enzyme from working so hard. And so we want to stop the enzyme in the periphery so the levodopa can get to the brain. But the problem is some of these bacteria that are out there and may be within our microbiome, these bacteria also have that activity of the enzyme. So they can break the levodopa in periphery. So some presence of this genre of bacteria or these species of bacteria that increase the activity of this enzyme can break our levodopa and make us not have a very good response to levodopa itself. And some of the bacteria that have this property are Enterococcus and Lactobacillus. So these are the ones that can worsen the symptoms. So this study is a very interesting study that is often quoted in many literature that are out there in Parkinson's disease and GI system. And what they have done in this study is that they took mice that had motor dysfunction, fluctuation, and this mice had this typical microbiota, and the microbiota of these patients showed that they have certain activity that promoted motor dysfunction, and the patients showed a lot of the mice showed a lot of Parkinsonian features. What they did is that they cleared the microbiome of the mice. They completely cleaned it up, and it became germ-free. And so none of this activity existed anymore that was promoting the fluctuations and motor dysfunction. And so we just had the mice, they only saw very limited pathophysiology there in the brain. And then They gave that microbiota from that mice and gave it to another mouse that didn't have Parkinsonian features, and that itself drove motor dysfunction in that mouse. So that tells us that whatever is happening in the microbiome or microbiota, with the effect of the genre or type of bacteria that is out there, can have a negative impact on our motor function and can promote the pathophysiology of Parkinson's disease. Now, I mentioned that I will come back to this genre, the Prevotella, the type of bacteria. Prevotella is an interesting type of bacteria that resides in the colon. It interacts with the immune system, and it's very important for making of thiamine, folate, and all these other vitamins. If you have low amount of Prevotella, you will have low mucin, and therefore you will have increased permeability, the leaky gut, and then local and systemic exposure to bacterial endotoxins, and therefore you can have all these local environmental triggers can trigger Parkinson's disease and can lead to expression of alpha-synuclein and Parkinson's symptoms. So Prevotella is important, and it seems like Prevotella is low or not enough, or the abundance of it is decreased in patients with Parkinson's disease. So if it's that good, can we use it as a biomarker? Then the unfortunate thing is it's not as a specific. It seems like it's good, sensitive. It's very sensitive, but it also can be seen in other conditions like autism or even diabetes type 1. They can have lower amounts of Prevotella. So it can't quite be used as a biomarker yet. One of the questions that one of my patients actually asked me once was, is the gut microbiota related to the type of Parkinson's disease? And this study, sure enough, has been done in patients with Parkinson's disease. And they looked at case controls and Parkinson, and then they looked at different subtypes of Parkinson's disease too. What they did is that they took the DNA of the stool samples and they wanted to see what type of bacteria are present in people who have different subtypes of Parkinson's disease. And you probably know the subtypes, the PIGD. These are people who have postural instability, gait disorder, or people with tremor-dominant Parkinson's disease. They looked at different subtypes, and they looked to see if Parkinson's disease, healthy control, and these different subtypes have different types of bacteria. What was interesting in this study is that they found the same findings of the previous studies that I mentioned just earlier, that patients with Parkinson's disease have decreased amount of Prevotella family as compared to controls. The controls had it more. But when they looked at the different subtypes, they didn't see that the subtypes have much significant difference in the type of bacteria among themselves. So the only thing that was significantly different was really the presence of Parkinson's disease versus not Parkinson's disease. And they then looked at the pro-inflammatory, anti-inflammatory subtype, and they see that the type of, I'm not going to go into details of this, but the bottom line is that when they compared the healthy controls to Parkinson's disease, they saw that Parkinson's disease patients seemed like they had bacteria that were more pro-inflammatory as compared to healthy controls. Healthy controls had more bacteria that were anti-inflammatory compared to Parkinson's disease. So that's the same thing that we mentioned earlier, that it's kind of the balance between pro versus anti-inflammatory bacteria. Another question that very commonly comes up is fecal transplantation. what should we do? Is fecal microbiome transplantation a good way of treating Parkinson's symptoms or not? And that's something that I'm going to show you a study about. There are several studies that show that if you do fecal microbiome transplant, you can have some improvement in constipation. But even when we talk about constipation, you don't have improvement in consistency of the stool. It's the number of this spontaneous bowel movements that had improved. There's this case series that looks at quality of life, non-motor symptoms, and motor symptoms of patients with Parkinson's disease who had FMT, fecal microbiome transplant. And they showed that when you look at these patients, compared them, they followed just in 3 months, and they saw that these patients had some improvement in their motor function up until 3 months. And they also had some improvement slightly in non-motor symptoms. Then this is a non-motor symptom questionnaire that asks about a lot of other non-motor symptoms, including constipation. And then overall, PDQ-39 is a quality of life questionnaire that they also reported that maybe these patients had some improvement in their quality of life as well. And you look at this bar chart of satisfaction versus no satisfaction, that you see that some patients had satisfaction throughout. They were always, like, even when they followed them for 20 months after one FMT, these patients were quite satisfied. But it's kind of a mixed picture, and some others didn't really have much improvement or satisfaction. And this is certainly something that has some placebo effect to it as well that should be considered. So it seems like the next steps are to confirm which one of these bacteria are the most important ones, are sensitive and specific, and how can we, not just by colonoscopy or endoscopy, which are kind of invasive procedures to be done every 3 months anyway, for the patients, if there are any other ways that we can give the good bacteria to the patients to improve their microbiome, and that's something that needs more research into it. One other thing that I do want to mention before I move on to the next slide is although fecal microbiome transplant is an interesting concept, it has its own limitations and possible side effects. That the microbiome has to be cleaned before you transfer the next microbiome, or it has to be kind of lavaged or treated with antibiotics. So it's not a risk-free procedure. And before we know that it's actually helpful with help of clinical trials, we shouldn't jump into asking it for our patients. These are going to be brief. I'm going to talk to you about prebiotics, probiotics as well, and the definition of what these are in literature. Prebiotics are non-digestible food ingredients that aim to have benefits in stimulating and growth of certain bacteria that are overall healthy for the colon. Probiotics are live microorganisms that are administered in some adequate amounts that then get into the microbiome and promote activity or can stimulate growth of certain type of bacteria. So this is, in theory, what we hope probiotics would do. We hope that probiotics should improve constipation, improve gut motility, and be pro-inflammatory, decrease the inflammatory markers, and therefore enhance the gut barrier and inhibit the harmful bacteria to get into our nervous system in the GI tract and promote any badness from happening, or prevent promotion of badness, I should say, from happening. So these are, in theory, roles of probiotics that we wanted to do. But in truth, the fact is that we haven't seen that in the studies that have been done, probiotics actually achieve that, at least up to this point. So these are the current status that we say yogurts, products that are out there that contain live or active cultures. If they do not have enough, studies behind them, which a lot of these actually don't, they kind of trick the buyers that this is going to do this and that, and unfortunately, there's not enough limitation in industry, unfortunately, and they're promoted and they're pretty expensive too. We, at this point, we encourage our patients to have healthy diet as opposed to going after these supplements, really. The products that contain probiotics, they should be safe in general. They may be helpful for the general health, but at this point, like I said, there's not enough evidence that, in fact, they will prevent the alpha-synuclein aggregation or prevent the process of Parkinson's disease. So no improvement no data for improvement of quality of life in these products either. As I mentioned, the current evidence tells us that probiotics can help with constipation, but the quality of the studies that have done this are not very high quality studies, so that has to be, taken with a grain of salt. There's, we mentioned average stool consistency. There's no difference between people who take probiotics and not. Other symptoms like abdominal pain, distension, other symptoms that we see that are due to motility are not affected with probiotics. So the final points are anti-inflammatory changes in gut microbiome is likely, at least to some extent, to be responsible for the process of neurodegeneration. Parkinson's disease may start in the gut. In fact, it probably does in at least some group of patients. And in fact, it's important that the trigger of the whole process is dysbiosis, changes of microbiome in patients with Parkinson's disease. But to this point, there is no evidence that probiotics or prebiotics can do anything in prevention of Parkinson's disease. So all we need to do is healthy eating habits for now, and sticking with eating lots of goodness that is out there. If you want to spend money on expensive products like probiotics, spend it more on berries that are probably the same price, but are more likely to be helpful for gut health, and try to stick with healthy habits, lots of spices, good salad and olive oil, which is a Mediterranean diet, really, lots of nuts and seeds and beans, and coffee is nothing. Just the beans of coffee can be helpful for constipation as well. You want to stick with lots of hydration, different types of teas that can help with hydration and have some antioxidant properties to them as well. Try to have less sugar, less soda, less dairy milk, but more coffee, more tea, more water for hydration, and try to include all of these into your habit of shopping list and make sure that you stick with it every week. So just a fun ending that some animals have not won by force stomach, and they do well. So we can eventually find our way to treat the symptoms, hopefully, as well. And these are some good material for reading. If you are interested in reading more about gut health. And this is people in my center. Right, I think I'm 4 minutes over, huh, Amy? back to you.
That was fantastic. Thank you so much. I personally have quite a few questions, so we'll get started.
Yeah.
Can you confirm and then can you repair a leaky gut? So is there a way to be tested to know if you have one, and then can you fix it?
That's such a good question. So to be tested, no, because this is testing at a microscopic level, and in regular colonoscopies that patients have, these are not tests that we regularly do. However, as part of many studies, these are things that are really drawing attention of many researchers at this point, and there are several studies that are looking into the gut right now, and many of them I know they are interested in looking at the inflammatory markers, and will probably look at the leaky gut as part of that too.
Do you see any benefit with us knowing if there's a leaky gut? Would
Not
that
until
change how you would treat Parkinson's in the future?
Not until there's a good treatment for it. What we think is it is related to inflammation. So if theoretically, if you can suppress the inflammation, you should improve that process well. But we're still at the process of understanding that these two are closely connected. And so the next steps are, like you mentioned, improving inflammation and with that improving the leaky gut as well.
How do you distinguish between gastrointestinal issues such as the bloating, the fullness, the motility versus a gastro issue, as colon cancer? It seems like a lot of the symptoms are the same. So how do you distinguish as a patient, should you see and what should you be looking for?
Thank you for that great question. One of the things that we want to always point out to our patients is that patients with Parkinson's disease, epidemiological studies show that they get, unfortunately, less care than their peers because everything is summed up as, oh, you have Parkinson's disease. So I always encourage my patients, you should have a very good regular follow-up with your primary care. All your screenings have to happen right on their time. But back to your question of how can we distinguish? These are red flags. There's some red flags associated with cancer. So weight loss, if you have significant weight loss in a short period of time, if you have any sort of bleeding, if you have sudden onset of like severe pain, these are what we call red flags. And even when you bring it up to your neurologist, so when I'm assessing a patient who has fluctuations, I assume that all patients with Parkinson's disease after 2 to 5 years of onset of symptoms will have fluctuations. They will have symptoms that are not as regularly controlled by levodopa as they were a few years earlier into the diagnosis. But if their fluctuations is accompanied by any of the red flags, such as severe weight loss or severe abdominal pain or malnutrition, signs of vitamin deficiency, these are the things that make me think this is the time that I need to refer to a gastroenterologist. This is the time that I don't treat it just as a regular fluctuation. So it's important to think about those red flags.
Okay, thank you. Another question, you said the microbiome is passed on through birth. What about women who have been diagnosed with Parkinson's and are having children or have had children prior to being diagnosed but end up being diagnosed? Are they going to be passing on a subpar, for lack of a better word, biome to their offspring?
That is such a good question. It is possible that the type of microbiome that patients with Parkinson's disease have, even before their onset of motor symptoms, is different than healthy controls, people who don't have it. So it is possible that you're also passing on a microbiome to the offsprings, but truth is a lot of other things have to happen together for Parkinson's disease to happen. Some exposures, significant environmental exposures that will affect the microbiome. So it seems like some some of these factors should sit together to trigger the aggregation of alpha-synuclein. So it is not enough to pass that microbiome for the offsprings to have Parkinson's disease, or else we would see it as a pattern of a lot of these children of people with Parkinson's disease can have PD as well. What we know about Parkinson's disease is kind of a combination of different factors that can all cause Parkinson's disease altogether.
Okay, thank you. You said lactobacillus is one of the ones that kind of help interferes with the conversion of levodopa to dopamine. So that's found in a lot of yogurts. So should we be avoiding that bacteria in our yogurts?
So it is known that we should try to limit our dairy as much as we can, and the literature on cognitive decline also agrees with that you can, if you have a lot of dairy, you can have worsening of cognitive function too. So that's something that in general we tell our patients. And interestingly, from a clinical observation and from what I have learned from my previous mentors as well, people who have tremor-dominant Parkinson's disease, it seems like when they are exposed to dairy products more, they can have more tremor. Their tremor can be a little more. It's all not well studied, so I just leave it here that it's a possibility, and certainly that's something that we tell our patients, if they can avoid dairy as much, they should.
Okay. Somebody asked about SIBO, the best way to treat SIBO.
So SIBO, so there is an antibiotic called rifaximin that is helpful for treatment of SIBO. But SIBO, the problem with SIBO is that the testings of SIBO are not really well. So there's a breath test, glucose breath test, that the patients will drink some glucose drink, and then they will blow into tubes every 30 minutes to see if that bacteria that is producing some gas, is the gas amount increasing in those tubes as they continue bloating or blowing into the tubes or not. And if it is increased, then they say, oh, you do have SIBO. The problem with that test is sometimes you repeat it 2 days later and it's coming back negative, or sometimes you treat with antibiotics, the test is still positive. So we don't have a great test. And sometimes we do a combination of testing along with clinical picture and treat some patients who have severe bloating and it's bothersome to them, fluctuations. But they then, after a few weeks, they develop SIBO again. The SIBO will come back because we treated the bacteria, but we didn't treat the underlying reason for development of SIBO, which is motility problems in a small intestine. And so they develop it again. There are some other groups of antibiotics too that are way more stronger than rifaximin. Rifaximin is well tolerated and it's not systemically absorbed, so doesn't have a lot of side effects and can be tried in certain patients. But I usually talk to my gastroenterologist colleagues as well in treating SIBO.
Okay. If you can improve your constipation and become a little more regular, does this improve or slow development of the disease? So, I mean, I guess if you're fixing the leaky gut and you're preventing those alpha-synucleins, does that change disease progression?
That's such a good question, and I know we only have 2 minutes. It's possible, but probably will not reverse the process of the disease. The improvement of constipation probably has some improvement in response to medication. So people who have severe constipation, a slow motility in the stomach, in colon, can also have a slow motility in the neighbors of colon, small intestine, and then the stomach. And so their medication may not quite work that well. So we try to improve the constipation for better working of levodopa. But by the time that you have Parkinson's disease, the alpha-synuclein has, if it started in the gut, has found its way to the brain, and it is in the brain already. So by improving constipation, the process of disease cannot be reversed, but symptoms, quality of life will improve, and absorption of medication will improve. So we really encourage patients to work on constipation improvement.
Okay. We've got time for one last question, and I'm gonna kind of combine a couple into one. So if you have a lack of response to levodopa, is there a practical way to see if that is due to the, absorption in your gut because of motility? And then would an elimination diet or something be beneficial to see if that helps to improve your GI issues?
If you have complete lack of response to levodopa, there are some patients who don't have good response to levodopa. We look at some other things. For example, we look at presence or absence of dyskinesia. When you say lack of response, does it mean that it's not improving what symptom? Tremor, bradykinesia, is it rigidity? Because tremor is also a kind of a tough symptom to control. There are some patients who levodopa does not control their tremor, but they're developing dyskinesia, which is a side effect of the higher doses of levodopa. So that means that it is actually being absorbed in their system, and it's not having an effect on the symptom of interest, which means we have to move on either to the next medication or the next approach for treatment. So that's a completely different, and it's very different from one patient to another. It has to be examined to see why that a specific patient is not responding. There are some research ways of measuring plasma level of levodopa as well, and that's something that can be done in a specific patients.
Thank you so much. I wish we had more time because there's so many more questions coming in. Everyone, we will be posting the slides in the presentation later, so you can go back if you missed anything. Dr. Safarpour, thank you so much for joining us and for providing so much info. I mean, this is just something that I found so interesting. I learned so much, and I have so many more questions I want to follow up on. Everyone, thank you for taking the time to join us today. I'm sorry I wasn't able to get to all of the questions, but I hope that you are able to walk away with some information that will help you live a good, healthy, active life. As with all the topics we've been presenting this year, I think the main theme is eat healthy and exercise. So everybody go out, enjoy the beautiful day, and have a nice rainbow-colored meal. Thank you, everybody, and we'll see you next month.
Thank you.